Okay, my name is Hayes Gladstone, and this is Ellen Marmer, and we're moderating the Controversies section, which I think should be entertaining and thought-provoking. The objectives, just reviewing the way it's going to go, is the objectives are to discuss the pros and cons of electronic brachytherapy, microneedling, and fractional resurfacing, and then also whether a non-invasive lifting is better than surgical lifting, and then also pros and cons of EMR and to describe EMR, and then whether non-dermatologists should be able to own practices, and a slew of other things. The format of this actually is a little different than previous years. Each speaker is going to have 5 minutes, and then there's going to be they're going to be given a 1-minute rebuttal against the other speaker, kind of a debate format. And then hopefully at the end we can have discussion, or if you have questions or comments, feel free to come up to the speaker at the end, but please hold your comments until we finish the entire session. We're going to start out with pro and con electronic brachytherapy for skin cancer. John Carucci had a family emergency, so Ellen is going to ably substitute for John. Ellen, as you know, is associate professor at Mount Sinai and is also the founder and president of Marmer Medical and a very prominent cosmetic dermatologist and Mohs surgeon. Welcome.
Thank you. Woohoo! Okay. This is meant to be polarizing, so each speaker has been told to stick with their one side here, so I'm going to go for con. So what we're doing here is trying to kind of shake it up, and we really want to hear what you guys have to say. It's really, really good when people are passionate in their opinions, and this is a debate format. So I am standing in for one of my mentors, John Carucci, who couldn't be here today. He would wear a baseball cap and giggle the whole way through, but I can't giggle like he does, so I'm going to keep moving forward. And Hayes, this does not, okay, there we go. So what is electronic brachytherapy? Well, what is it not? It is not your traditional external beam radiation therapy. It does not use the iridium. It does not have the cure rates over 5 years that the traditional does, and we don't know much about its long-lasting major skin issues or potential toxicities, such as the recall radiation dermatitis that we know from traditional radiation. These are some of the studies that are done for the traditional radiation therapy for skin cancer, and we do not have this rich database for the electron brachytherapy here. Electron brachytherapy uses this little X-ray miniature tube and does not use the iridium as we mentioned here. So to date, there's really one study that was presented in 2013 at the ASTRO meeting where they used many different skin cancers, so 275 non-melanoma skin cancers in 187 patients using a 2-millimeter margin, only going down to 3 millimeters in depth. And you can see here that they use CT scan for determining the thickness of the lesions. I would argue we do not have a good imaging methodology for measuring thickness of lesions, even with the ultrasound, until it gets better, more sophisticated here. They were given 2 treatments a week. Almost twice as many males than females. 73 years old was the mean age, mainly Caucasian. And you can see there were mostly basal cell and squamous cell, only 1 basosquamous, which as we know is more aggressive, 2 Merkels, and 4 others. Nose and face were the most common locations here. And the tumor sizes were arguably very small, less than 1 centimeter. So the question I would raise here is, why can't a Mohs surgeon take this off? The acute adverse effects, many people had grade 1 adverse effects like dermatitis and pruritus, and you'll see photos later of the side effects over the weeks during treatment therapy. My main point here also is that there's only 38-month follow-up in this one study. It's a single-center study. It's not a multi-center study. I think Steve will show us later another study here that showed a 97.5% cure rate with a higher number of fractions, so higher dose than this study, with significant adverse effects in the lower limb lesions, which we see with Mohs surgery also. The workflow of electron brachytherapy uses this gorgeous, elegant, laser-looking machine, but does bring in a whole team of people. A radiation oncologist is necessary, radiation therapists, physicists. The patient comes in the room, With a portable shield, we don't need the lead walls. The machine is calibrated and treated. It takes about 15 minutes once you get started, 2 times a week, but you don't know how many treatments they're going to need and how many weeks of treatment they'll need, and it can be done in the office. So they bring it in and out inconsistently, or you can buy a machine for, I think, about $300,000 and then pay it off as you go. True examples of patients who really, really, really wanted this treatment. One, a math professor, can you guarantee I won't have any pain, no scar, and I'm going on vacation and I don't really want to wear a bandage on my nose. I have patients who say, I'm going to a party, or I just don't have time for this, or I have to travel, can I wait a few months? I would say, this is skin cancer that we're talking about, so those types of lifestyle considerations may not be valid enough to go for a non-surgical treatment. Patient number 2, a 72-year-old patient who still works because she doesn't have enough money, has a limited budget, has had Mohs successfully with great results in the past, was seen by a radiation oncologist who apparently convinced her that she should pay out of pocket the discounted rate of $10,000 to have electron brachytherapy rather than Mohs surgery, which was covered by her insurance. Here it raises the economic issue and considerations of what's ethical in this situation. The third patient here is a patient who was referred after squamous cell in situ on the entire ear and did well with electron beam radiation. Now, these are patients who had the treatment, and I would show that I just bet most of us could do just as good of a job with the Mohs surgery, even to let it granulate. This patient has a white contracted scar on the alar rim anyway, and would possibly do even better with the skin graft. Here's a patient on the temple, also treated. I bet I could get an even better scar in just one day. This is 3 years after. Another patient, scar on the nose, looks kind of just like my scar from my basal cell, treated by Mohs, 1 stage, and no grafting or anything. Again, is this any better cosmetically? Is it worth the time investment to have treatment with electron brachytherapy? Here is mid-treatment. You see the circle and swelling. Then the skin breaks down, becomes necrotic, and you do have weeks of a healing process, a granulation process. The morbidity is significant. Here in the medial canthus, it's not that close to the tear trough or anything, but I think most of us could just do Mohs surgery here and let it granulate. Also here on the mandibular angle, it's not large. It can be treated with Mohs, maybe even 1 or 2 stages and sewn up. And finally, 4 months after, again, this patient had to go through many weeks of treatment in and out of the office. So, is there enough data? There may be good data for the high-density brachytherapy since '84, where they've done thousands of skin cancers there, and they have several studies out to 82 months. But don't be misled. The electron brachytherapy is not the same and does not have the data to support it. And also the reimbursement ethics. Ethically, how can one choose a treatment that costs at least 10 times more than another similar treatment? Our patients will do what we tell them to do. While it is common when a new technology appears in medicine, the reimbursement might be higher. Part of the rationale for that is so that practitioners can use it, they can experiment, get more experience with it, and that Medicare collects the data and then decreases the reimbursement over time. But is that ethical without proper studies to essentially experiment on cancer patients when we have a viable proven option such as Mohs or excisions? There should be transparency in the societal cost of Mohs versus electron brachytherapy, as well as possible patient payment liabilities. Because of cost, ethically, shouldn't its use be extremely limited? Maybe patients who are in nursing homes and they can't travel in and out, they could bring the machines to them. Electron brachytherapy is different from the traditional. It is aggressively marketed, it is tempting, and it really does reach right into your morals and ethics, which is best for the patient, not what's best for the practice profit. How does it compare to surgery? I would argue it's no better in all of these important variables here in terms of cure versus control of local disease, cosmesis, risk of subsequent cancers, operative safety, and cost effectiveness. We don't know what the risk is of subsequent cancers. You think about X-ray treatment for acne many years ago, and I have a lot of patients in my practice who have scars all over their face now, and they really wish they did not have X-ray therapy for acne. So we don't have long-term outcomes for here, and we don't know what other things we could be creating. We actually don't have data here either about the operator and environmental safety in a dermatologist practice or an outpatient clinic. It's not fully developed here. So the cons I am going to conclude with here is that the temptation for abuse is very real from a business medicine perspective. The reimbursement for Mohs is about $1,500 versus about $25,000 per case here. Treating inappropriate patients will discredit our field of dermatologic surgery. There's no 5-year evidence-based, well-designed multi-center trials yet available. We have no consensus guidelines to tell us which types of cancers or how many treatments are necessary. There's poor data on complications and long-term risks of other cancers. It has an enormous societal cost, money, time, and it's considered experimental by private insurance companies. It's considered experimental because it still is experimental. Anyone can rent the machine, not just dermatologists, so this could be the family practice medicine, or anybody else can just start taking care of skin cancers without the wisdom and experience that we do. Radiation oncology could take over and possibly just hire derm PAs and start doing derm exams and biopsy and eclipse the role of the dermatologist. So that is the con for electron brachytherapy.
Great. Thanks, Ellen. And I'd like to introduce Dr. Steve Kurtzman. He's actually a radiation oncologist, one of the pioneers of this therapy for skin cancer, along with California Skin Institute. Thank you for coming, Steve.
Well, it's a pleasure to be here. Thank you for inviting me. And she seemed so nice in the hallway when I met her just a few minutes ago. Anyway, I'm sorry, go ahead. I'd actually just like to start out by kind of gauging the audience. How many in here are dermatologists? How many do Mohs? How many radiation oncologists are there? Yeah, I really like my odds here. I brought an X-ray tube to a knife fight, clearly. Anyway, let's get on with the discussion. What is this?
It's the green one. I used the page down.
Which one?
I just used it on here doing just page down.
Oh, page down, okay. Okay, first things first. I do not disagree. I believe that surgery is still the mainstay for the management of skin cancers. I would never argue otherwise. What I would argue is that there are a sizable number of patients who are appropriate for radiation therapy and specifically electronic brachytherapy. Radiation is really complementary to the dermatologic practice. Really the patients who benefit most from radiation are really patients who are not great candidates for surgery, or where organ preservation, which is a basic tenet of all radiation oncology, where they'll benefit from that. So cosmesis, functionality, healing issues. So for instance, I would absolutely get Mohs surgery for myself if I had a small lesion on my cheek or my shoulder, my arm. I probably wouldn't if I had it at my commissure or my inner canthus. I probably wouldn't recommend surgery for my mother if she had a squamous cell cancer on her anterior shin. I think there are, and she has multiple medical problems, I think there are definitely a subset of patients who do better. This concept of radiation versus surgery is not new. We're used to getting you guys through this existential crisis of accepting radiation. 30 years ago, the issue was breast cancer and breast conservation, and every woman had to have a mastectomy according to the breast surgeons. 20 years ago it was head and neck cancers, where we're going to saw off half your mandible, take apart your neck, and then send you over for a full course of radiation because we couldn't possibly get the cancer out. With chemo and radiation, nobody gets head and neck surgery anymore. And finally, near and dear to my heart, prostate cancer. I do quite a bit of prostate brachytherapy, and the urologists initially 10, 15 years ago basically told me this doesn't work. Now, most of them have abandoned prostatectomy. So radiation as conservation is a sound principle and has been for a long time. There is a very long history specifically for radiation in skin cancer. Madame Curie really discovered the properties of radiation back in 1898, and the first patient was treated over 100 years ago using radium needles. Since that time, technology has advanced. so that we're not using low-dose rate brachytherapy sources or isotopes, but more electronically generated X-rays. And then there's superficial radiation. There was orthovoltage radiation. Then when Linux came along, there was electron beam radiation therapy. And then more recently, high-dose rate brachytherapy using iridium. And again, electronic brachytherapy is the relative newcomer. But if you understand radiation biology, if you understand the physics of radiation, you would know that arguing about the energies and the fractionation schemes is a little bit like arguing what kind of scalpel you're going to use to do surgery. If you understand those principles, there's not really a lot of mystery. And again, as radiation has advanced over the years, we've seen the integration of new technologies without the need for 5, 10, 15-year follow-ups. There is a long history of radiation, and it's successful. It works. Actually, I think this is a very similar slide to what my colleague showed here. And essentially, the bottom line is this. The cure rates for radiation are essentially in the 94 to 99% range for primary tumors, and for recurrent tumors, somewhat less, but 87 to 88% in most of the studies. So again, it's got a long history of success. Again, what I hear is when people will say things to me like, well, I don't believe in radiation therapy. That to me is a little bit like saying I don't believe in antibiotics. You kind of lost that right to even claim those things because there's so much good data out there that radiation works. Dose fractionation is an important aspect of this. And in fact, I'm glad she brought these up in the other thing. You can find dose fractionation schemes ranging from 6 fractions over 2 weeks all the way to 35 fractions over 7 weeks. And the difference is the long-term side effects are dependent on fraction size. So if you use less fractions and higher dose per fraction, you are going to get more complications. And the reason is this: radiation damages both normal cells and cancer cells. If you give a big whopping dose per fraction, you overcome the normal cell's ability to repair. So if you give lower doses but at a higher dose per fraction, you're going to end up with some of those non-healing wounds, some of those hypopigmented areas. So we tend to fractionate these out a lot more than what she had shown in the studies that she cited. This is mostly for radiation oncologists. Basically, what I wanted to get across in these next few slides is electronic brachytherapy actually has advantages from a physics perspective over electrons, over photons, over iridium sources. Essentially, it allows us to give a much smaller field of radiation to be much more conformal to the lesions we want to treat, okay? And it gives a much more homogeneous dose distribution across that treatment field. So I'll skip through these. This is an HDR applicator using iridium. And you can see on this graph, the depth dose of the radiation is essentially identical. This graph shows the homogeneity of the radiation across the electronic brachytherapy field relative to the iridium. It's much flatter, much more homogeneous. So the clinical advantages of the radiation are that we can treat these patients in the derm office because the low energy radiation requires no special shielding. That really promotes a truly multidisciplinary approach to treating these patients. Because it's so low energy, the patients can be treated while the therapist is actually in the room with them, just using minimal shielding. So it makes for a much more personal treatment. It makes for much easier monitoring of the targeting. So who are the ideal candidates for electronic brachytherapy? Essentially non-melanoma skin cancers, squamous cell basal cells. We treat lymphomas, we can treat other things, but the 99.9% are the basal cells and squamous cells. Generally, we want to treat less than 5 centimeter lesions, and the patients we choose either are at issue for cosmetic outcomes with surgery or non-healing issues. So, for instance, commissure, eye, ear, nose, lip. If it's important to the patient not to have a surgical defect, we will treat them with radiation. Again, fractionating at a lower dose per fraction and more treatments, actually the cosmetic outcome is uniformly good. Any patients who are anticoagulated, so patients with vascular disease who are on Coumadin or Plavix, these are patients that you don't necessarily want to take off those medications. You can do surgery. And we can also use this as adjuvant therapy for high-risk patients at risk for recurrence. So the process is actually fairly straightforward. The nice thing about skin cancer is we can visualize it. The first step is what we call a simulation session, where we target the lesion, we immobilize the patient, and then we set the field sizes. When we have our field sizes, that's set off to our physicists who do calculations to assure that the dose is correct. Each treatment from start to finish usually takes about 10 minutes from the time the patient lays down until the treatment's delivered. It's painless, there's no anesthesia required. And again, the physician and the therapist can be in the room with the patient, which tends to be pretty comforting to them. Side effects, essentially, again, if you fractionate this outright, you're going to get some erythema in the treatment field. Occasionally, you'll get some moist desquamation. And that's pretty much it. Generally, the patients have no pain. We manage them. We look at them clinically every day to make sure that they don't get any moist desquamation, and we'll give them breaks if need to. But that's about it. Again, if you fractionate correctly, your cosmetic outcome is excellent. In general, we have a tough time even seeing the area that we treated when we do somewhere between 12 and 15 fractions as opposed to 8. I'm just going to show you some examples of this because I think our product is our best advertisement. This is a 90-year-old woman with a 3 cm squamous cell on her ear, and you can see what it looked like at the beginning of treatment. On the right is her treatment setup. On the left here is the last day of treatment, so she's got some erythema. At 6-month follow-up, you can see that this is healed up beautifully. Another one, a patient with a basal cell in the tip of his nose, 15 fractions, and at his follow-up visit, I would defy you to even find where the treatment area was. Another eyelid, again, one I think that would be difficult surgically. Same treatment regimen, 15 fractions, 1-year follow-up, absolutely beautiful. This is a patient with a squamous cell carcinoma of the leg, and this actually is my mother. We treated her. That's her leg, and we treated her with 12 fractions, and again, she had a beautiful outcome, no healing issues, worked out very nicely. Another example of a lower extremity lesion in a vascular path that turned out well. Let's just skip to this. So, actually, I wanted to show these as well because I think this brings out your point. These are a quicker fractionation scheme, that 40 gray and 8 fractions. And you can virtually assure that you're going to get hypopigmented areas when you do that. And you can see on this patient clear hypopigmented areas. Okay, more examples. This guy had multiple lesions. Just another example of a squamous cell on the hand. Again, another area on an older gentleman that could be surgically difficult. Anyway, I'm going to run out of time. So in conclusion, I think electronic brachytherapy is a viable treatment option for those patients not suitable for surgical resection or who are very concerned with cosmesis. Bringing this into the dermatology office and not requiring cancer centers and shielded rooms really fosters a multidisciplinary approach to treating skin cancer, and I think it just helps complete a comprehensive cancer program for dermatologists. Thank you.
Okay, thank you very much. Although that was convincing, I have to still stay with my con perspective here. Given the data that we've seen, this is mainly used for small lesions. Although your outcomes were beautiful, especially on your mom, which almost won the case, I think that in our offices, all of the Mohs surgeons in here could do surgery in a much shorter time, which with this similar morbidity and even better or similar cosmetic outcomes. I think the societal costs here still favor in-office procedures with Mohs surgery, particularly for higher risk cancers, such as the recurrent skin cancers, which had an 84 to 88%, I think, success rate with the electronic brachytherapy. I think that this is interesting. It's not going to go away, but we still need 5-year data. We need multi-center studies. We need all kinds of different cancers in all different locations and parameters for patient inclusion and for treatment guidelines. And I'm still con.
She didn't listen to a word I said. Yeah, no, I think, again, I think if you listen carefully to what I said, I think that it's properly selected patients. So at California Skin Institute, where we do radiation, 5% of our patients go for electronic brachytherapy. 95% still go for Mohs surgery. So again, I would never make the argument that this is a blanket treatment for everybody. Again, cosmetic outcome, vascular paths, people that you don't want to take off their anticoagulation, people that you're worried about healing issues. I think this has a real role in the management of skin cancer. Thank you.
Thank you. That was great. So we're looking for an even better fight next with two of my favorite people, Dr. Doris Day and Dr. David Goldberg. Dr. Day is an associate clinical professor at NYU. She's won awards for her teaching and dedication. She's also an incredible mentor. She's open to giving her opinion and her expertise to all of us and has really contributed to my practice almost as much as Dr. David Goldberg, who is my mentor, my fellowship advisor, and the man who wears more hats than anyone I know in our professional societies, and who is also a wonderful resource for advice from lasers to skin cancer and also to legal issues. We are going to be talking today about microneedling. Please, Doris, Dr. Day. Thank you.
All right, it's a big ticket to battle against Dr. Goldberg. So, but here we go. So, microneedling. So let's just start off with what are our options to do? So in my office, I have a lot of different devices, and I've spent a lot of good money on these devices, and I've put a lot of thought and effort, looked for hard science behind them. Every single laser and non-laser device I have costs in the range of, let's say, $60,000 to $140,000. And has really good science, targets in the skin. I know exactly what I'm doing, exactly what I'm getting. Lots and lots of published papers in peer-reviewed medical journals that tell me why I need this device and what I'm using it for. And I can tell you, one is I paid for all of these devices. Two is that I use every single one that I have, and I love every device that I have in my office. So there's a reason behind my choosing what I choose. And there's a lot of hardcore medical data. But lasers, as I mentioned, do cost a lot of money. And so if you're just starting a practice and you're trying to decide, what do I need in my office? How am I going to spend this money? How am I going to get patients in? I can understand how it's a difficult decision. And it might seem a little tempting to cut corners and to look for a device that costs maybe in the $1,000 to $5,000 range, depending on where you're starting, that seems like it can sell a big number and offer something to your patients. But I caution you that you sometimes get what you pay for. Most of the time, that's the case. And when you cut corners or you start with something that has a limited amount of science, you can end up in the wild, wild west. And we're not talking about just new territory. We're talking about potentially very dangerous and destructive wild, wild west. So we need to be really careful about the devices we pick and what we're doing with them and how we're using them and how we're selling them, because everything has consequences, and we need to pay attention to those consequences. So we don't want to be in this wild, wild west where we don't know what we're going to end up with. So this little derma roller, microneedle, in its various forms, whether it's in a manual form or an electronic form that you can plug in that they can sell to you for a little bit more money, can come with these needles of all different shapes and sizes that can penetrate different depths of the skin, can be used with or without different products. And I say this very broadly because it's like a little bit of this, a little bit of that. We'll kind of mix stuff in with it, see what we get. None of this has really great testing or science behind it. It's kind of all out there, different people trying different things. Some studies, not a whole lot, nothing I've seen that's been very impressive, and that's why I'm not showing you a lot of slides with a lot of clinical data. And then you can end up looking like this after treatment. So it's not really a no downtime thing, depending on the depth of the needle you're using. And God forbid you're not using a great brand and one of those needles is dull. You run that over the entire course of the skin and you can end up with some serious problems. This is what you can look like right after with a more aggressive form of it. And these are all the different needles. You hope that they're all well made and sharp and well maintained and cleaned and not really reused from one patient to another. And you want to know who's doing the treatment. Hopefully it's someone who knows what they're doing with it. But the problem is this. Sometimes if you use the wrong device or the wrong person does it or they use the wrong products with it, you can end up with permanent scars. This is 6 months after a microneedling in the forehead, and you can see basically she's left with a grid-like pattern on her forehead of red papules that sometimes get better, sometimes don't, but they're basically there all the time. She's devastated by it. It looks like she has an imprint of a baseball cap on her forehead. And she's been treated with steroids, topical oral steroids, oral antibiotics, topical antibiotics, had some IPL and some other treatments. Lots of things have tried, but if you look at this close up, this is an imprint in her scalp that's there permanently. I did a biopsy, and it showed an inflammatory papule. It was a granulomatous dermatitis, and they thought maybe it could be sarcoid or rosacea-like papule. No bacteria or fungi, no foreign body identified, just a dermal inflammatory infiltrate with lymphocytes and giant cells. So this is somebody who now has to deal with this when she was otherwise perfectly fine. So my thing is, if you're going to be in the wild, wild west, you do need a sheriff in town, and hopefully there'll be a new sheriff in town who can watch over this and and make sure that we're kept safe. Thank you.
OMG. All right, let's see. Okay, so my disclosure is I've spent 29 years being a laser guy. I've written, 10 books on lasers and laser resurfacing. I'm the chief editor of a laser journal. I'm also chief medical officer of a company that puts out a microneedling device. But I have to take the other position because Ellen told me to. So first of all, they're not all as disgusting looking as she showed you. This is an example of a microneedling device that's pretty sophisticated. Doesn't cost $100,000. And this is not a new technique. It's been around for a long time. It's known as percutaneous collagen induction therapy, fractional dermabrasion. You know, you put some sort of peel or something on the skin to exfoliate, something we do all the time. You ablate the skin with this device instead of an ablative laser that she showed you, and you can even put products in the skin. So I have no interest in this company. They just happen to make a nice microneedling device. This is the MicroPen. It's a high RPM, consistent system. You can dial the depth that you want to deliver the needles to, and it's got single-use needles, so they are clean and they are sterile, Doris Day. So microneedling, also called percutaneous collagen induction therapy, gives you precise micro-injuries if you use a good device. And the results are what you would get from any other wounding process, collagen and elastin production, and you can use it in combination with a variety of topical things. And of course, its major advantage is it's really cheap. I mean, that does matter. There is some data showing that these devices work, that you can produce improvement in patients. And there is a big difference between some of the newer devices and the old hatchets that you just saw from my adversary. You can get a reliable depth of penetration. You can adjust it, and you can adjust it to the patient's needs. And these better devices have vented tips. They allow for airflow in, and they control the amount of fluid that is there. So there's a difference between a dermal roller from the Wild West, which I guess is New York, because that's where Doris is from, and these newer devices, which are certainly much better. And there's some clinical data. You can see improvement here in fine lines. And the fact is, any patient that you're going to consider doing resurfacing on, you can treat with a good microneedling device. Fine lines, skin laxity, diminished texture, tone, color, atrophic acne scars, even stretch marks, photoaging, some patients with melasma, and certainly the large number of patients with a limited budget. So here, this is Jody Comstock's patient with acne and acne scarring. Here you can see another patient with acne and acne scarring, and another patient as well. And you can see close-up. These are all with microneedling devices. So in the end, microneedling, yes, it's true. It's a poor man's laser. There's nothing wrong with that. You potentially can rip the skin. You don't generally do that with the better devices. And of course, you wouldn't get that from a laser. But they do work. And the question is, can we do better? And this is a company I've become involved in. And this is the AquaGold Fine Touch device, which is a microneedling device, but it's the delivery system attached to it. So in that sense, it's totally new. And so you can deliver products through these little needles, and you deliver treatments into the skin. You get faster absorption because of the microneedling process, and each of the needles is so tiny it is near painless. They are 20 screw thread design surgical grade stainless steel microneedles. Each needle is smaller than a human hair. They're each plated with 24 karat gold, and there's both an in-office version, which delivers to 600 microns, and a home use one, 250 microns. And of course, with any microneedling device, including this one, you can stimulate collagen formation. The screw thread recess in the microneedle enables it to penetrate well into the dermis, and you can deliver whatever you want. So you not only microneedling, you can deliver neuromodulators, diluted HA fillers, growth factors, PRP, whatever you want. And here's histology showing products being delivered through this microneedling delivery system. And here you can see improvement in décolleté using this microneedling type device. So in the end, I'm a laser guy, but you can't knock this Wild West woman. This works.
Okay, it's really hard to come up with a rebuttal. I have to say, it's a very great presentation, and I agree with both sides of it. The funny thing is that we were assigned, can I just say this? We were assigned these presentations, so in my office I actually do microneedling, and I'm not entirely against it, but I did my best to come up with a con for it. I think really the reality is it is a poor man's laser, and while there can be a role for it, I think you just have to be so careful about the products you're using with it, knowing that you can get scarring. Just because it's not a laser doesn't mean it's not a medical device, and doesn't mean that it can't do harm. So you have to respect the device, even if it doesn't have an expensive price tag that comes with it and a plug that you have to, or a heavy-duty outlet and energy source that is attached to it.
I was tempted to rebut you during my talk, but I held it off. All right, so she showed you serious oozing and bleeding and scarring, did she not, from a microneedling device? Mm-hmm. So who has seen oozing from lasers that produce resurfacing? Everybody, right? And who has seen scarring from laser resurfacing because either wrong laser, wrong patient, wrong person, mid-level? Who's seen that? I rest my case.
Okay. No. No, that is totally not resting your case. It's one thing to say that you can have oozing and scarring from a laser device. Of course you expect that, but it's a known endpoint. You're reaching that endpoint on purpose, and you know exactly what you're doing. With the microneedling devices, there's 1,000 different devices out there made by every single brand with so many claims that are not backed up by evidence-based medicine and hardcore science. You need the science behind it. With lasers, before they can get that clearance and that approval, they have to go through a process, and even afterwards, we talk amongst ourselves and we speak at these meetings about what these devices can do. You can do serious damage and think that you're just playing in a playground with like a few needles.
That's right.
Excuse me. So we're going to start a registry looking at the incidence of terrible scarring from laser resurfacing versus microneedling. You don't get another chance to rebut me. You're done.
Great. Thank you very much. Thank you. Great. Our next speakers are going to be Lisa Donofrio and Kathleen Welsh discussing non-invasive lifting versus mini lifting, pros and cons. Lisa is a well-known thought leader in our society and practices in New Haven, New York, and New Orleans. Welcome.
Thank you. Because I consider myself a dermatologic surgeon, I do a lot of surgery. So I want to talk today about a minimally invasive submental neck lift. I really don't have any disclosures for this talk that are relevant. What this is a full neck skin dissection done through a submental ellipse where a small amount of skin is taken with or without a neck liposuction and oftentimes with a platysmal plication. The ideal candidate are patients with the most laxity and fat in the central neck area, and those that would be good candidates would not have terrible skin tone, but would have the type of skin tone that you would assume would retract. So this is really the ideal candidate. This is a 50-year-old, and they will often come in and do this sort of positional laxity thing where they say, look, when I bend down or somebody took a picture of me or I selfied myself and I have this redundant skin in the anterior portion of my neck. And this is a before and after of this little submental neck lift. You see the nice smoothing and tightening of the submental area. This is a patient with a little more going on. Not only does she have some lax skin, but she has banding of her platysma muscle that I was able to plicate. The submental incision is approximately a 4 by 1.5 centimeter ellipse. Everything is done through that incision hole, including the plication and the complete neck dissection. And what I really like about this is after doing so many years of neck liposuction closed, this is a beautiful way to see the anatomy of the neck and to leave an appropriate amount of subcutaneous fat in the neck and not eliminate everything. So I feel like I'm visually remodeling the fat in the neck area. We know there are 3 platysmal patterns. When you end up with a type 1 or type 3, it's really nice to do a corset platysmoplasty. I use non-absorbable sutures, and I do usually about 3 interrupted sutures. Post-operatively, I think it's very important to tape these patients to get the skin to adhere to where you want it, and we leave this tape on for 3 days. This is what the incision looks like. This is at 2 weeks. I usually take the sutures out at 5 days and stereostrip them, and usually at a year you can't even see the scar. The cons of this are that it doesn't address lateral neck laxity. You do have a scar, which is in the submental area, but easy to hide. And by the way, a great procedure for men because there's no periauricular scars. It is a moderately complex surgical procedure, and although it's minimally invasive, it's invasive. The pros are, for the patient, it has a very quick recovery time, 5 days, and it doesn't look like they've had anything done. I do a lot of these on Fridays. The patients go back to work on Monday with just a little Band-Aid under their neck. The entire procedure for the physician takes 1 hour. There are no ear scars. It is very predictable. Unlike broad heating devices or non-invasive devices, I know exactly who the good candidate is for this, and it's not this sort of nebulous, well, 30% of people might get this, or you're looking at the before and afters and you can't really tell the difference. It addresses platysmal bands where the non-invasive heating devices do not. This is the most important. It cannot be taken over by a non-physician or spa. This makes you the dermatologic surgeon, and it makes you the expert. Just a few more before and afters. Before and after. There's that tiny little scar. This is at a month. And that's it. Thank you. I stayed within my time.
Great. And now Kathleen Welsh, who's director of the Bay Area Center for Cosmetic Dermatology, and which is probably one of the very top cosmetic centers in our area, is going to actually talk about non-invasive lifting.
What's the forward clicker?
I think they're having some issues. You could use this, I think.
Let's see if that goes. Is that already gone?
I think so. I may have touched it.
Okay. Well, here are my disclosures. I'm going to take the opposite point of view that non-invasive skin tightening is better than minimally invasive facelifts. I'm not going forward, sorry.
The other way is to hit the arrow.
That one, got it. Here are my disclosures. When a patient comes into my office and says, Dr. Welsh, should I have a mini facelift? 9 out of 10 times, I say no. And I tell them I personally would have every single minimally invasive procedure done, and maybe done more than once before I would personally have a facelift. And that's because there are no do-overs with plastic surgery if something goes wrong. And these are advancing automatically. Sorry. So why are patients afraid of plastic surgery? You see a patient, someone like Meg Ryan, who is rich, beautiful, and has effectively derailed her career because of a poor outcome from her surgery. I also tell my patients that tighter doesn't mean prettier. And this is a great study from JAMA Facial Plastic Surgery that shows that perceived attractiveness was the same before and after a surgical procedure. And we all know it's not just loose skin. What about perceived age change after facial surgery? In this Archives Facial Plastic Surgery article, patients before were judged to be 2.1 years younger, 1.6 to 7 years younger after surgery, but there was only an average of 3.1 years in perceived age change after surgery. And I love this picture.
Goldie Hawn in this picture is about 65. She looks like a woman in her 60s, but she's neither attractive nor natural looking. Next to her is her husband, who is 5 years younger than her. And he has facial laxity, heavy eyelids, but is attractive because he appears natural. How long does a facelift last? After 5.5 years, jowl correction relapse is about, and these are full facelifts, not mini facelifts. Jowl correction is 20%. The neck relapse is about 70%. What about a minimally invasive or short scar facelift? In this 2006 article, at 2 years, more than 50% of the sample needed a tech procedure to correct jowling and redundant neck skin. There are very few articles that compare non-invasive lifting to surgical facelift. This dermatology surgery article from 2013 looked at fractional radiofrequency, which is somewhat invasive. It could not compare on laxity, but fractional radiofrequency achieved 37% of the results of a surgical facelift. What about non-invasive skin tightening? Little or no recovery, no downtime, you don't have to wear a chin strap, minimal risk of infection, scarring, or bleeding, but mostly a very natural appearance. And I believe when we put energy into the skin and we treat the dermis and we treat the fibers septae and we tighten the SMAS with energy, we are getting 3D tightening. Surgery, the directions are all one-dimensional. The vectors are all unidirectional. Does non-invasive skin tightening work? I think we have enough studies now that show that there's increased dermal collagen and elastin fibers after treatments with both radiofrequency and intense focused ultrasound. 60 to 80% of the patients show some improvement in skin laxity. There's clearly less response in patients with a BMI greater than 30, excess submental skin, smokers, or patients with major skin sagging. So good candidates are surgery adverse, happy with a modest improvement, younger patients with minimal laxity, post-facelift patients who've developed laxity, and post-lipo patients. Here are some of Dr. Leslie Bauman's high-frequency ultrasound patients, and I would say that this is a near-surgical result. Another one of her patients, a little Botox to that platysmal band, and we have really a fabulous result with no downtime. So, in my practice, we have a saying, the age you start doing procedures and using products is the age you stay. But I believe with non-invasive skin tightening, we actually see a Benjamin Button effect. Patients appear to age backwards. Here's one of my patients over a 10-year period who's had 2 skin tightening procedures. In the second picture, she's 52 years old. Another one of my patients started with me at 41. She's had 1 ultrasound treatment about 2 years ago and appears younger than she did in her early 40s, and she's now 51. And this patient started with me when she was 38. She's had 2 fraxal resurfacings, 2 skin tightening procedures, 1 radiofrequency, 1 ultrasound, and here she is at 50 years old. So non-invasive lifting is better than mini surgical lifts because the age you start is the age you stay, and there's a Benjamin Button effect. With surgery, you age starting from the date of the procedure. With lipo, you do get some skin tightening. It's better for the patient because there's no downtime. There's few complications. It can be done by a physician extender. There's no calls in the middle of the night because you need to evacuate a hematoma. But I think most importantly, no one has to get a terrible 3D tattoo to hide any neck irregularity or any scars.
I would rebut that although you've shown those beautiful 10-year follow-ups, that we really don't have good data on non-invasive skin tightening in the long term and financially for the patients, how much they have to maintain it. But here's the big rebuttal. We are losing our skill set as surgeons, especially the young dermatologic surgeons that are not learning liposuction and are not learning surgery in their residencies anymore because everything is so device-driven now. We really need the skill set to continue. We need to really push the boundaries and the expectations that we should be having for ourselves as surgeons. And as my mentor, Bill Coleman, said when I was a resident, when you do real surgery, nobody takes it away from you. And if you think that doing Botox and injecting fillers is surgery, you're wrong.
I totally agree with that, Lisa. However, I don't think it really applies to the conversation. Non-invasive skin tightening is better than a mini facelift, and the reason is it's really better for the patient in many cases to take a non-invasive approach.
Excellent, thank you. Okay, so we're going to rumble next with Dr. Heidi Waldorf and Dr. Mary Walla. We are going to be, Dr. Heidi Waldorf is from New York. I've worked with her for so long. She has an academic practice as well as a private practice, an associate clinical professor, and our game at Mount Sinai was to always say, where in the world is Heidi? Because she is the most zipping around speaker internationally, so she kind of knows what everyone is doing on every continent of our planet. Dr. Mary Walla is obviously one of the most up-to-date, knowledgeable members of the ASDS. Both of these are future presidents of the ASDS. And she just had a baby, right? And just started a private practice and and writes books and articles and is incredibly productive. So today, what we're going to dispute is that all physicians should use EMR.
First, thank you guys. Ellen's laughing because she's heard over the past year was the worst year of my medical career to date, and it is all because of EMR. And that is actually not subjective. That is objective. Is this the forward? What am I pressing? Page up, page down. Page up. Okay. So this. Page down. Yeah. So disclosures obviously mean nothing here, but references, resources, anecdotal, my personal experience and my colleagues, and a bunch of articles that have pulled together cases that have come up of the various things going on in EMR from various companies. And if you look back, there are even further studies from back in the 90s and 2000s talking about how this was going to be a disaster. Oops, wrong way. Here we go. So my experience just in private practice, I have Nextech. Our initial launch was September 30th, 2013, and I think what says it all is we needed a complete relaunch from the same company on August 18th, 2014. My faculty practice, we actually still have paper records except for 2 physicians at one off-site location who have started Epic, and we just got a notice saying that we got permission not to start Epic until they find out that it'll be reasonable for us in the main part of the faculty practice. Personally, I don't take insurance, I don't take Medicare, I'm purely cosmetic. The private practice, however, though, has 2 other providers, my dad and an associate who do medical dermatology and are Medicare providers. So here's the first problem, cost. What is the direct cost? The implementation, the software, tremendously expensive. The hardware tablets, desktops, printers, routers, cables. Remember, many of us are in buildings that were not built or offices that were not built out for computers, for all the wires that we were going to need. I have constant discussions even with my electrician in the old Scotty, we need more power kind of, but Captain, I'm doing the best I can. We're going to have to rip out walls at some point to do this. I have a colleague who in Connecticut who has had to lay down his own fiber optic network between his offices. The maintenance, this becomes an ongoing part of our overhead, as is, if you look at our overhead now versus 20 years ago, it's significantly higher because you can't have a dermatology practice without some devices. In addition, in the old days, even for filler, what did you have to stock? You stocked collagen. And now what are we stocking if we truly want to be able to offer patients the best? We have to stock many things. Indirect, what's the training involved for patients, for physicians, for staff? And productivity during the implementation, you've got to cut down. These companies tell you, oh, no patients for 1 day, half patients, blah, 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 on and on. And for at least 6 months to a year or more, you have reduced productivity. We still aren't back. Accessibility, local, Wi-Fi cables. Offices, as I said, aren't designed with EHR involved. One of the computer guys we brought in said he went to an office where every time they shut a glass door in the office, all the Wi-Fi beyond the glass door was off. So Wi-Fi can be wonky. And depending on your building and your setup and what you're doing, Wi-Fi can go out. If you have desktops, remember, we're still dealing with internet providers, and none of them are perfect. How many times does your own home internet go out? Power outages. Please, we've all seen across the country, the sort of, plague-type weather we've been having at times, and you have blackouts, you can't get to your records. What about the acute issues with your vendor? Vendor systems routinely have service times, and they'll say, well, oh, we're doing service. But what if they're doing service over the weekend and you still see patients, or they're doing it in the evening and you're still seeing patients? Chronic issues, vendor technical support. I don't care what company you work with, the technical support, they're not in-house. Difficult time, and it is consuming to make any changes. It's hard also to transfer between vendors. Next, liability, the notes. This comes from my malpractice carrier. The templates, every note looks the same. A jury is going to say, but doctor, how do we know you even saw the patient? It doesn't reflect our thought process. Typos. I go in and I'll see that it looks like I did 11 syringes of something instead of 1 because you type 1 on the iPad and it clicks it twice. What about electronic tracking? When anybody goes into that record, it can be tracked. Someone opens it at a later date, having nothing to do with changing records or anything, it's still going to show that that record was open. The internet, problem with backups, problem with hacking. And then in terms of actual errors in hospitals, for example, and in terms of sending in prescriptions, there's no centralized reporting of errors that have happened, medical errors due to electronic records in hospitals or individual practices, but there have been huge cases and thousands of malpractice suits already. The personal aspect of the job. What about eye-to-eye contact with your patient? Well, you lose that. My nurses complain about losing that. This is not intuitive. There's less free-flow conversation because you have to ask questions to fit into those little templates. There's a need to fill in the blanks. And what about problem solving? We all went through training and learned, there would be that attending who would come in and no one could figure something out, and the attending would come in and go, I hear you've led an interesting life. And suddenly you'd find out the answer to the story. And that is, the loss of that open-ended question is gone in electronic medical records, unless you're spending the time to type it all in, and then it takes forever. You're never going to get done. False promises and hazards. I'm nearing the end here. Billing. Documentation. Everybody's documenting for meaningful use. Meaningful use is meaningless, as we all know, for what we're doing as physicians. And yet there are going to be people who are going to do this very well, and there's potential for fraud, for upcoding. Compatibility, remember, these systems are not compatible. They don't speak to each other. Patients think they're going to be able to walk around with their records. They're not. And linking electronic health records to electronic medical apps is not always easy either for people who have specific things. Frankly, I will tell you, even for documentation, we had patients from outside of the country, and trying to put in medications that are not in the list of medications, or the dose is not in the list, is near impossible. Thank you for your kind attention. And for the record, I'm considering taking the loss and chucking my medical records, my electronic ones.
Okay, so I'm going to tell you why, and I don't mean this to be too controversial. Well, I guess that's the point. Heidi, I think you might have chosen the wrong thing, so let me explain why EMR is the way to go. I have no financial disclosures to make. I have not been paid by my EMR. I don't get a discount by my EMR. Nothing has transpired between me and my EMR, but I love it. I use Modernizing Medicine. I have used Nextech, Cerner. I've used the VA system. I've used eClinicalWorks, and I've used Epic. I'll tell you why you need an EMR. Here's the bottom line, 3 things. You ready? Safety, time, money. That's how you make a decision. Here we go. Safety. This is what a typical paper chart looks like. And you're going to tell me that you have the time to sit there and look through all the patient's medications, or, oh, Mrs. Smith, are you still taking this, which was charted, 10 visits ago? That's somewhere in the middle of that stack. Are they pregnant? Are they planning on being pregnant? Because your intake form that you did, 4 years ago is still valid for a young person who's coming in for acne? Really? What are their allergies? Is there anything new? Consents. A lot of times people spend a lot of money organizing their paper charts when you can have it all at the touch of a button. And then let's not forget finding charts. Don't you love it when people come in and you're like, oh, they're coming in for a walk-in visit and we don't have their chart because it's in storage in the other building and we haven't seen them since 5 years. That's helpful to you, right? No. Here we go. Documentation. If you can tell me that you can read every note that you've ever written, I'd be surprised. In our faculty practice at Stony Brook, people used to go home with bags full of charts. You can't do that. How many times have people experienced something where you're missing the paper? And it will always be that one consent that you need, right? So this is what a note looks like in my office. Let's talk about safety. Images. Photos are part of HIPAA. You need to be able to establish that there's a chain of possession in them. It is not faster to take a photo and then scan it somewhere onto the one computer and then back it up on a hard drive and have it backed up as a third place and then keep track of who's been logging into and out of that computer. What if your nurses at the end of the day don't put it into the right folder and now you're looking back for the most consult? Photo cannot be found. This is all in one place. You also need to be established who looked at the record. When did they look at the record? And again, because you have an EMR, individual logins do all of that for you. So you can tell me that it's much better to not have an EMR, but then you're going to tell me Polaroids were so much better and easier than digital records. Polaroids were faster. Digital images are much better. Time. So let's talk about patient interaction. So Dr. Waldorf correctly pointed out that we've lost some of that eye-to-eye contact. Well, guess what? We don't really do it. They did a study from 60 routine primary care office visits among 22 family practice residents. And guess how long it took them to interrupt the patient? 12 seconds. So if you're going to tell me that as physicians we have this amazing rapport with our patients, we're looking them in the eye and we're engaging with them, we don't do that now. But with an EMR, if you have a scribe in the room who acts as your MA, you can actually spend that entire time talking to the patient while the person who's next to you is writing in what they need to write. So time, writing the note. For example, I do Mohs, I do cosmetics, and I do some general derm. It takes a lot of time to remember what all the different Mohs indications are for the new guidelines. In my EMR, it's broken down into specific areas: location, size, histology, complicating clinical features. It's compatible with the CMS guidelines, and I can override any of it. So this is what the area looks like if I'm doing Mohs. Really quick, do a couple of tabs, fill it in. My note is done. I can fax my report, and my images are uploaded. Okay? That's not a lot of time. That's good. Let's also talk about time. How about that little friendly phase, ICD-10? It's mandatory. It's not an option. So in ICD-9, you have 13,000 codes. In ICD-10, you have 141,000 codes. So, okay, let's do this experiment. Is paper actually going to be slower than your EMR? How fast can you write down 4 ICD-9 codes? You can rattle them off right off the top of your head right now, right? Takes you what, 5 seconds? All right, now write down 12 ICD-10 codes. Yeah, that's a lot longer. Okay, no problem. You're going to work around it. You're going to do ICD-10 on a super bill because you're not going to do an EMR. Well, you could do that. That's how big your font would be, and that super bill would be 41 pages. Remember, in ICD-10, you have to code skin cancer and exact locations. My EMR has it already in it. Remember, nevi have laterality. So if you think that you can just quickly put arrows everywhere and a bunch of dots, that's not going to be acceptable in ICD-10 because you have to bill it. Again, this is time. EMRs are so expensive, right? So we talked about safety, we talked about time. Now let's talk about money. So is the space that your charts are taking up. Let's say you have a 10 by 10 room because you've been in practice a long time, and on the low end, you generate $100 an hour per room. You work 4 days a week, you work 8 hours a day. Guess what? For that chart room, you're spending $160,000 a year. So don't be mistaken that EMRs are somehow so much more expensive than the money that you're unknowingly spending now. Let's also talk about meaningful use and also reductions in pay. If $500,000 in Medicare collections, remember that you're going to take a hit of about $20,000 if you can't do PQRS. My system happens to have PQRS built into it. And even if it didn't, your EMR is going to allow you to search by diagnosis to do the PQRS mandates. In 2014, providers were required to report on more than 50% of their qualified patients. You can't do that by hand. You really can't. To gain a 0.5% incentive, which that's not much of an incentive, but what you're really trying to do is avoiding a 2% penalty. So this is what my bill looks like at the end of the day. I've done my visit, I've done my codes, my ICD-10s are in there, and I've done my PQRS. So the bottom line is, it's better for safety, it's going to save you time, and your money, you're not actually going to end up spending as much as you think. So I think you should get an EMR.
And while I respectfully, I think that was a great outline, what I want to add is a few things to the cost. The suggestion that we need a scribe. My nurses, when they're with me, if they're sitting typing, they're not preparing. Normally, as I'm speaking, they're laying things out for the procedures, they're running and getting things. So do I need yet to pay for another person in the room to be a scribe? If they're writing it, I still need to take the time to review it. So, because I can't just trust what they're doing, and then am I spending the time adding? So am I really writing the note twice? In terms of space, again, it depends on where you are in the country.